السلام عليكم طلبتنا الأعزاء. Today's lecture is about strabismus الحول أو أيضا الناس تنطي اسم ألطف باللهجة العامية تسميه الردة. Certain definitions we need to know. What is the visual axis? It is the line of vision passing from the fovea, which is the center of the macula, through the nodal point of the eye, which is just behind the posterior surface of the lens, toward the point of fixation at the object of regard. There is another axis, which is called the anatomical axis. It is the line passing from the center of the posterior pole to the center of the cornea. So if you can imagine, the anatomical axes of the two eyes are parallel to each other, while the visual axes of the two eyes, they intersect. They meet at the point of fixation, which is the fixation target, and this is in order to achieve normal binocular single vision. So what is binocular single vision? It is the ability to fuse the images from the two eyes and to perceive binocular depth. يعني من نقول binocular single vision, it means using our two eyes to see one image with depth in 3 dimensions. So for a squinted patient, when one eye is directed to an object while the other eye is directed to another object, he's probably seeing a double image or diplopia, رؤية مزدوجة. هل كل مريض عنده حول يعاني من الديبلوبيا؟ No, this is not the case. How we get rid of diplopia? By 2 mechanisms: sensory adaptation and motor adaptation. What is sensory adaptation? It is suppression at the level of the brain. It is an active inhibition at the visual cortex for the image coming from the deviating eye when both eyes are open. So in order to get rid of diplopia, the child with squint will suppress the image coming from the deviated eye and will see only the image coming from the orthotropic or straight eye. What is motor adaptation? أو التكيف الحركي? It involves the adoption of an abnormal head posture when the patient will turn his head into the direction of the field of action of the weak muscle, so the eyes are automatically turned into the opposite direction as far as possible, and we will explain this in the following pictures. The abnormal head posture is analyzed in terms of 3 components, in terms of face turn to the right or left, head tilt to the right or left, and chin elevation or depression. An example of adapting an abnormal head posture: this child who presented to me, and the parents complained that she is squinted in certain times and not squinted in other times. A general look to the patient showed that she is tilting her head to the left shoulder. So this gives me an impression that she might having a problem in her right eye. Usually, right eye superior oblique palsy will cause right hypertropia in a primary position. So by straightening her head, we will find that the right eye is at higher position than the left eye. And by doing an opposite head tilt, that is to say, by tilting her head to the right side, we will demonstrate the large angle hypertropia, as you can see. So the child chose to run away from the field of paralysis and the field of maximum squint by adapting an abnormal head posture. What is amblyopia? Amblyopia أو كسل العين. It is a reduction in the best corrected visual acuity caused by either vision deprivation, يعني الحرمان من الرؤية, or abnormal binocular interaction, يعني الحول, for which no identifiable pathology of the eye or visual pathway is found. يعني نفحص العين راح نشوفها تشريحيا سليمة لكن الوظيفة متأثرة، يعني هناك reduction in the visual acuity in spite of normal anatomy. هذا الحرمان من النظر vision deprivation or the abnormal binocular interaction الحول should occur before the age of the visual maturation يعني before the age of 6 years in order to cause amblyopia. What are the causes of amblyopia? Number 1, strabismic amblyopia. This is due to continuous monocular suppression for the image coming from the more deviating eye. Number 2, anisometropic amblyopia, when there is difference in refractive error between the two eyes, so there is suppression for the image coming from the eye with more refractive error. The eye with more emmetropia will produce a severely blurred image, and this image will be suppressed at the level of the brain. Number 3, stimulus deprivation amblyopia, like congenital cataract, الماء الأبيض, congenital ptosis, هطول الجفن الولادي. This will cause stimulus deprivation, الحرمان من الرؤية في وقت مبكر من العمر. Number 4, when there is bilateral amytropic amblyopia, when there is high refractive error but it is symmetrical, usually in the form of hypermetropia. Usually myopia, only higher degrees of myopia causes amblyopia, while hypermetropia and astigmatism, even low degrees, will cause amblyopia. So bilateral amytropic amblyopia when there is high symmetrical refractive error. Meridional amblyopia, this is from the image blur in one meridian, يعني الكسل المحوري, usually due to uncorrected astigmatism more than one diopter in early childhood. إذن الحول الفرق بالأخطاء الانكسارية بين كلتا العينين، الحرمان من الرؤية لفترة مبكرة مثل الكاتاراكت congenital cataract congenital ptosis، كذلك bilateral emmetropia يعني bilateral high refractive error especially hypermetropia. and number 5 meridional amblyopia اللي هو الكسل المحوري for the uncorrected astigmatism also early in childhood. How we can treat amblyopia? This is by occlusion of the better seeing eye. So the best and most common method to treat amblyopia is by patching the normal eye in order to force the brain to use the image coming from the amblyopic eye. Of course, the younger the child, the better the response. Amblyopia sometimes in adults and in even late teenage, sometimes very difficult to treat. How we classify squint? We have two major categories, comitant strabismus and incomitant strabismus. Incomitant strabismus, it is almost equal in measurement at different gaze positions with full ocular motility. So the differentiating feature between comitant and incomitant is testing ocular motility. When we have full ocular motility and the patient have the same angle, let us say for example esotropia in a primary position, the same angle of esotropia at left gaze, the same at the right gaze, there is minimal difference, almost the same angle, this is comitant strabismus. While in comitant strabismus, there is usually a difference in gaze positions due to either muscle restriction or paresis, so it may indicate a neuromuscular or an orbital disease. The incomitant strabismus will be covered by other lectures, and we will discuss some examples for comitant squint. For comitant strabismus, we will discuss few types, the most common types. For esotropia, which is convergent squint, we will discuss the congenital esotropia, the accommodative esotropia, and sensory esotropia. And for exotropia, which is the divergent squint, we will discuss also the congenital, number 2, the alternating divergent squint, and 3, sensory exotropia. What are the clinical features of congenital esotropia? It is an idiopathic condition that usually starts within the first 6 months of life in a totally normal infant. So the child or the infant is normal, it is healthy and wealthy, no CNS abnormalities and no other features, and there is no associated significant refractive error. So no hypermetropia seen in these children. Also, there is full range of ocular motility, no limitation of ocular movement. Usually the squint have large angle, as you can see in the picture, and the child assumes the phenomenon of cross fixation. We will explain it, and sometimes there is associated nystagmus. What is cross fixation, which is an important clinical picture seen in congenital esotropia? Due to having large angle esotropia, the child will prefer to use his left eye to fixate a target in the right visual field and to use the right eye to fixate a target in the left visual field. So in order to differentiate this condition from bilateral 6-nerve palsy, sometimes we need to do patching for half an hour or sometimes more in order to force the child to use the unpatched eye to see at different gazes and to demonstrate the full range of movement. Treatment of congenital esotropia is usually surgical, and the eyes should be aligned by the age of 1 or very latest for the 2 years in order to not to lose binocular single vision. And the most common surgical procedure is to do recession of the medial recti in both eyes. We call it bimedial recession. What is accommodative esotropia? Due to the presence of high refractive error in the form of hypermetropia, the child will do excessive accommodation in order to increase the refractive power of his eye. As you know, the hypermetropic eye is an eye with less refractive power. When the normal is about 60 diopters, a hypermetropia of +5 means that the eye have 55 diopter of refractive power. So this +5 refractive error, hypermetropic refractive error, will make the child obliged to do excessive accommodation. And we explained accommodation in the practical sessions, you have to review it. This excessive accommodation is by increasing the power of the lens in order to increase the total power of the eye and to cancel hypermetropia. But because accommodation is part of a triad called the near reflex, which is composed of convergence, accommodation, and meiosis, and all these 3 components of the near reflex are quantitatively related. So, refractive accommodative esotropia is a physiological response to excessive hypermetropia, usually in the range of +4 to +7. The child will need larger than normal amount of accommodation in order to overcome his excessive hypermetropia to have a clear vision. So as you can see in the picture, this child have left esotropia due to high refractive error, high hypermetropia. By simple correction of his hypermetropic refractive error by using plus lenses, convergent squint is corrected. The third type of esotropia is sensory esotropia. It is the result of unilateral poor vision very early in life, usually before the age of 5 years. Examples for causes of poor vision: congenital cataract, congenital ptosis, corneal opacity, and sometimes there is a malignant tumor of the retina called retinoblastoma. When it obscures vision, the child becomes esotropic, and this could be the first sign to diagnose retinoblastoma. So a squinted eye sometimes have normal retina and sometimes have a life-threatening disease. Now for exotropia or divergent squint, we will talk about the three types: congenital exotropia, intermittent exotropia or alternating divergent squint, and sensory exotropia. Congenital exotropia, usually the onset is at birth. Again, we have large and constant angle and no associated significant refractive error, so normal refraction for the age. But usually there is associated neurological abnormalities like CNS abnormalities, like convulsions, etc. And again, the treatment, like congenital esotropia, it is mainly surgical. The second type of exotropia is intermittent exotropia. The presentation usually at the age of 2 years. Since the condition is intermittent, so we are not bothered about suppression because suppression will also be intermittent and it will not cause amblyopia. Usually, our aim is to stimulate the contraction of the medial recti by stimulating accommodation, and this is by giving minus glasses. So, just like we treated accommodative esotropia with the plus lenses, we treat intermittent exotropia with minus lenses. Surgery is usually delayed. When there is no correction until the age of 5 years, we will do surgery. So if the child is losing control, when the time of being squinted is more than the time being orthotropic, then we shift to surgery. And surgery is by weakening the lateral recti by recession, with or without strengthening of the medial recti by doing resection. Sensory exotropia, usually secondary to acquired visual loss after the age of 5 years. For example, accidents or corneal injuries. These may end with poor vision, very poor vision after the age of 5 years will cause exotropia. What are the types of surgery most commonly done? Either weakening procedures or strengthening procedures. Weakening procedures, the most common method is to do recession. اللي نقصد بيها إنه نرجع مكان الانسرشن into a position further from the limbus. So, when we make the insertion, the new insertion, closer than the origin of the muscle, this will make the muscle less powerful. Either we make a sling, as you can see in the bottom right, or we suture the muscle, the new position, we suture it to the sclera. This is recession. The most common strengthening procedure is to do resection, which is cutting part of the muscle in order to make it tighter. So we cut part of the muscle and we suture the rest of the muscle to the original insertion. When we remove and cut part of the muscle, we will make it tighter, so stronger. This is called resection. Resection is the most common strengthening procedure performed. The general steps in management of squint. These steps are used for any case that you face in the exam or in life. You have to put in your mind these general guidelines. Number 1, you have to take a good history, starting from the age of onset, the birth history, in order to differentiate between congenital and acquired squint. The developmental history is also important, any associated CNS diseases, any family history of squint, any past ocular history, past surgery. The patient may not volunteer to tell you without specifically asking about these points. Number 2, ocular examination, starting with Hirschberg test. We explained these things in the practical sessions by doing cover-uncover testing and by testing ocular motility in order to differentiate between the two major categories, comitant and incomitant squint. Number 3, anterior segment examination by the slit lamp, because as we said, sometimes corneal opacity, sometimes cataract are the pure causes for squint. Testing visual acuity and any associated refractive error is crucial, because certain types of squint, as we explained, like in accommodative esotropia, the treatment is by simply correcting the hypermetropia. Also, in alternating divergent squint, sometimes you just give an over minus, you give him minus glasses, and the problem is solved. Number 5, fundus examination. Dilated fundus examination is crucial because sometimes an optic atrophy is there, or a macular scar, or a malignant, life-threatening tumor like retinoblastoma could be presented in the form of squint. Number 6, you have to correct any significant refractive error, as we said. Number 7, don't forget to treat amblyopia by patching the normal eye, because simply giving refractive correction by glasses without occluding the better seeing eye will not correct squint. And finally, surgery is done when all the above measures do not fully correct strabismus. The last thing you need to know is how to differentiate between true and pseudosquint. There are certain cases when the patient looks squinted grossly, but if you examine him, especially by putting and shining a focused light on his cornea and noticing the position of the light, which we call this the corneal light reflex testing or Hirschberg testing, this will show us in the, as you can see in the left picture, this child have central and symmetrical corneal light reflexes, while grossly he looks esotropic. So his right eye looks esotropic because there is a large epicanthic fold, especially on the right side, a large epicanthic fold covering the medial aspect of the eye, giving an impression that there is right esotropia. While doing the corneal light reflex test, the reflexes are symmetrical and central. On the opposite, the pictures on the left, the upper one, the corneal light reflex is located on the temporal edge of the pupil. So this means that the right eye is deviated toward the nose. There is right esotropia. While the lower one, the lower right picture, the corneal light reflex is located at the nasal edge of the limbus. So this means that there is large angle right exotropia. Thanks for your kind listening, and please feel free to ask any question. Write to me anything that you didn't understand, and I will be very happy to answer it. I wish you good luck.